Welcome back, guys. Now we will discuss Adenomatoid Odontogenic Tumor. Before that, I'd like to explain to you the journey of the tumor. You know how the very first jawbone tumor we discovered and we named it after a long bone tumor which is known as adenomatoma because of similar histological features, which later on it was Churchill who established the term and who later named it as ameloblastoma, which is the prominent tumor of jawbones. As time progressed, we discussed tumors with calcification in it, which was usually named as ameloblastoma with calcification or calcified ameloblastoma or variants of ameloblastoma. But later on, it was Pindberg who named it as CEOT in 1955. In our last this class, we discussed CEOT and how it is very similar to ameloblastoma with certain distinguishing features. Now, a few times after that, they discovered another variant of ameloblastoma which show glandular features, glands like structures in histology. Radiographically, clinical features they represent ameloblastoma, but on histology there are certain features of glands in it. That's why this tumor, this variant was known as a variant of ameloblastoma or adenoameloblastoma. Adeno, they just add the name of glandular features. But in 1969, it was Philipson and Brown who named it as Adenomatoid Odontogenic Tumor, gave it the significance of a separate tumor. That's why it is known as adenomatoid. Adenomatoid means glands. Adeno means glands. Right? So everything going to be same as ameloblastoma with certain differentiators, which I'll tell you. On the clinical features, it's mostly affect the young patient, and it's one of the major tumors which actually occur in maxilla. For rest of the tumors, like for most of the tumors, they are more common in mandible than in maxilla, in posteriors than in anteriors. But AOT is rebellious, right? It's occur in maxilla and in anterior maxilla. It's very common in MCQs. AOT common in anterior maxilla, right? It's as usual it's more common in females. That's why ladies first, right? It's the first tumor in front of the oral cavity, basically the anterior part of maxilla. The smile, sessile mass, facial, see, these are just peripheral variant if possible. We have tumors of two kinds. They are central tumors and they are peripheral tumors. Central tumors are those which occur in bone or basically intrabony or intraosseous. Peripheral tumors are extraosseous, which are present in either mucosa or in a gingiva. Larger lesions, painless expansion of the bone. This is the same for every tumor. All tumors are painless until secondary infected. Basically, there is infection going on in the tumor or compressing normal structure. Same in all of the tumors. Right? Tumors do not hurt. That's why they are very developed stage, very advanced stage when they are diagnosed. 75% of the cases they are circumscribed, unerupted tooth and canine. In most of the cases they are circumscribed, right? They are involved with unerupted tooth, canine. That's why they become a differential diagnosis for dentigerous cyst. It's very hard to differentiate between a dentigerous cyst and AOT clinically or with a radiograph only. You need to have a histological investigation to differentiate between a dentigerous cyst or a AOT. Radiologically, as I told you, its features are very similar to dentigerous cyst. It's going to be radiolucent, localized unilateral, except there are small some part of calcification in the tumor, the snowflake calcification. That's why sometimes it just become a differential diagnosis of CEOT. If it is pure radiolucent, it is a very good differential diagnosis of dentigerous cyst, especially in case of it if it is present in anterior maxilla. Histologically, this tumor have the similar features of a normal ameloblastoma. Cell arranged in sheets and islands, as you can see, these sheets and island arrangement. Ameloblast like arrangement, as I told you, amyloid like material, it's very common. The only differentiator is present of gland like arrangement, glandular arrangement, which is this. This typical appearance is differentiator for AOT. This is glandular arrangement. If I when I discuss the glands, histology of the glands, you will able to tell this is how they appear in histologically. This is a glandular appearance, this is a glandular appearance, and because of that only the name was adeno given to the tumor. It's because of this particular features only. You can see a small amount of calcification. This is calcification. Same thing you can see in a histological slide. These are old tumors pattern. These are glandular patterns. On larger scale you can see these are all glandular patterns. Okay, this is the only differentiator. When they give you a slide, you just have to, I told you between differentiation of different type of ameloblastoma, all the histological difference I discussed in ameloblastoma class. In this, if you want to differentiate between AOT and ameloblastoma, if you want to just check out the AOT, you just have to look out for these features. If you can find them, it's at AOT. If you cannot find them, it's ameloblastoma. That's easy. Okay, otherwise these follicular patterns, you will find these follicular patterns in ameloblastoma also, in follicular ameloblastoma also. Adenomatous, you have to find these rings. Differentiator. What are all the differential diagnosis for the tumor? Dentigerous cyst, 101%. You are always, there is only possible way is histological investigation. Clinically, they will appearance very same. Radicular cyst, differentiator is AOT is mostly involved with impacted. Residual cyst mostly infected with carious tooth. Mostly, not mostly, all of the time is going to involve a carious tooth. Dentigerous cyst, they are most common with impact like in lower molars, right? But AOT is, you can say, not all of the time, but most of the time is going to present in anterior maxilla only. Lateral periodontal cyst, very confusing sometimes. All you have to look out for involvement of impacted tooth. COT or CEOT or COC, all these calcifications, they are differentiated to each other. You see calcification radiographically, you cannot differentiate them. Only differentiator is histological diagnosis only. Radicular cyst, its repetition, sorry. Then how we are going to treat it? It's a very circumscribed region, right? There is not much of infiltration into the soft tissue, into the bone, so it is very easy to enucleate or simple excision. You just cut out the entire tumor. Like for example, if this much is your bone and if this is your tumor, you can just excise the entire tumor only, and it's going to treat it. Their recurrence rates are very low, very low. Most of the time, if it's involved with impacted tooth, then you have to remove it. You have to remove the tooth also with it. So with this, we are done with AOT. We will meet again in next class. Thank you very much.